discriminatory practices. And also there has been bias practices within the medical profession that has focused on what people of color go through that are dealing with some type of dementia. So at this time, it's important for me to remind you of the association's mission, where in collaboration with the medical profession through its resources, it is, finding a way to find a cure for Alzheimer's disease and other types of dementia. And I say confidently that one day that we are going to be informed of a cure. And that is the reason why, we should be aware of its resources, because even when that day comes, when a cure is detected, people are still going to get Alzheimer's disease and other types of dementia, where research has determined that by year 2050, it's going to be as many as 13 million Americans that's going to be inflicted by some type of dementia. So based on that, I want to make sure that you are aware of at least two of the valuable resources that the association provides. One is its helpline, which is available 24 hours a day, 7 days a week. And when you're connected with the helpline, you are connected with very well-trained staff that, based on what you share with them, they will inform you of the resources that are available based on your situation. And then I also encourage you to look at information on the association's website at www.alz.org, where here on this slide, what you see is the specific sections of the website that will help you find resources in your local area. And I want to make sure that you're aware of the fact that the New York City chapter of the association provides services to individuals that reside in all 5 boroughs of New York City. This is the moment that I've been waiting for, and that is to introduce you to our guest speaker today, and that is Dr. Sakina Ouedraogo Tall. Dr. Tall is a geriatrician and assistant professor at NYU's Pearl Barlow Center for Memory Evaluation and Treatment. Dr. Tall has many focus areas, one being Alzheimer's disease and other types of dementia, which is why she's with us today. She was recently awarded a 2-year grant to launch a telemedicine cognitive geriatric program at Bellevue Hospital. Dr. Tall is currently the New York State Council of State affiliate of the American Geriatric Society. She's also a co-chair of the Health and Hospitals Geriatrics Council and is a fellow at the American College of Physicians. So today, Dr. Tall is going to talk to us about what an initial discussion with a medical professional should look like and sound like when you consult with them about concerns with memory loss. And she's also going to inform us of ways as to how we can improve our overall brain health. So at this time, it is my pleasure to pass over the presentation to Dr. Tall.
Thank you very much, Ms. Hills, for this kind presentation, and thank you very much to Dana and to the entire Alzheimer's Association New York City chapter for this invitation. It's a real pleasure and honor for me to be here with you today. I'm sharing my screen and talk about what I really do on a daily basis at the NYU Memory Center and also at Bellevue Hospital where I practice. So my main job is really assessing patients and people with memory concerns, caring for them and their care partners and caregivers. And it's really a journey for me when I get to meet a patient. They start from either someone who has some subjective concerns, and I'm happy to reassure the person that those are subjective concerns, and let's make sure that we maintain your memory and your quality of life, aiming for a healthy aging, which goes from health, quality of life, and this is really like based on culture. Everyone will define healthy aging according to their cultures and values, but really let's make sure that we maintain this level of function to someone with severe dementia and with requiring a lot of care, and so supporting them and the caregivers. So I really see the whole spectrum. So I have no conflict of interest to disclose, and Linda did a great job going through some data. And what I would like to point here is seeing here the prevalence of Alzheimer's disease as we get older. 5% in people age 65 and 74, 13% between 75 and 85, and up to 1/3 of people who are 85 plus have been diagnosed Alzheimer's disease. And this is what I tell my patients, this is common, 1 out of 3. So we have to know also that sometimes it's misdiagnosed. Some people could be told that they have Alzheimer's disease, and when we assess them, we're like, this is not Alzheimer's. And we have also some that are diagnosed late. So those are really the raw data that we have, that 1 out of 3 older adults have been diagnosed. We know that there are significant health disparities when it comes to healthcare in general, but also to the domain of cognition and care of patients living with dementia. And that's why I'm very happy that I'm working more into that field as well, and with the support that is coming with it. And this, when we talk about dementia, it affects not only the brain, it will also affect other comorbidities, hypertension, diabetes, cholesterol. That's the way people will be able to manage the underlying comorbidities, will also impact their health in general, and also lead to further decline of the memory. So it's really a disease that will impact the person as a whole, but not only the brain. And we know that at different stages, the severe stage, unfortunately, is really the stage of like profound cognitive and physical disability, requiring like the maximum of care. When people ask about how many years this could take, we don't know, just because we don't have good tools to predict how many years the disease course could take. What we can tell is that there are many things that could interact here. And when I will show you some data on different type of dementia, you understand why it's really hard to predict how long this could take. And aiming for a physical function and a healthy lifestyle and controlling other diseases are important when we try to really help with the disease course. And of course, we are all here to hope to prevent this from happening. We'll talk about that. So what is dementia? And often I get the question of, is that dementia? Is that Alzheimer's disease? So dementia is like the umbrella, and we talk about that a lot. And it's really like a decline from the baseline. So someone was able to function at a certain level who can no longer do so because of some decline in cognition, and this impacts their independence of daily living. This is what we'll call dementia. So it doesn't have to be only memory, it could be also language. So because of language impairment, difficulty finding words, difficulty writing, difficulty speaking, the person can no longer, let's say, today I'm speaking, I'm able to give my speech. If this becomes an issue in the future, God forbid, and I can no longer perform my job, this is called dementia. So memory, how much the memory is impacting the function, then this is what we'll call dementia. Because of the memory impairment, someone can no longer take their medicine. Because of the memory impairment, someone can no longer remember to pay their bills. So how is this impacting function? Also, we talk about executive function. This is all like planning, organization, handling some of those math, those finances, working with the computer, the cell phone. Those are all executive function. If this is impacting according to their baseline and people will need now support, this is what we'll call dementia. So, and it shouldn't be in the context of an acute illness. So some people like they were fine, then they're acutely sick, they become really confused, they're in the hospital, and they will be like, they have dementia. No, they have what we call delirium. This is acute. If we fix it, the person can go back to their baseline. We know that sometimes they may not go back to their baseline because this could affect memory on the long term, but we should rule out something acute or an acute depression, a mental health disorder. before calling this dementia. So the cause of dementia, if you see here on this picture, on the light blue, this is pure Alzheimer's disease. You could see here it's really thin, it's small. So pure Alzheimer's disease is rare and usually it's happening in younger people. As we get older, we have what we call mixed dementias. So in 30%, we have Alzheimer's disease and vascular dementia. So the changes in blood vessel, decreasing blood flow to the brain, people with hypertension, diabetes, cholesterol could have vascular changes, and this could affect cognition as well. So Alzheimer's disease and vascular dementia mix in 30%. You have Alzheimer's disease, vascular dementia, and other dementias in about 35-ish%, and you have other type as well. So, and you have frontotemporal, Lewy body, Parkinson's disease, all those could lead to dementia. So that's why when I say that sometimes it's hard to predict is because sometimes it's not just a pure dementia. So hopefully by handling the vascular risk factors, you can actually impact the disease course. So this here is like an autopsy or brain pathology. This is why we call the plaques amyloid plaques, because there's a deposition of amyloid plaques in the brain, and this breaks connections between neurons, and also some of them get accumulated in the brain and destroy the brain cells. And one we can understand why when there are no connections between the neurons, new information cannot be registered. I tell you, asking several times, what day is it today? I tell you the information, you don't register it just because the new information is not getting registered. So this is memory. This is in the memory area that there are changes happening there. And this progresses, unfortunately, this spreads throughout the brain, and this is why we call it a progressive disease. So racial differences. First time I saw this phrase, older Blacks are twice more likely to have Alzheimer's than whites, I was puzzled and I was, what's going on here? And looking more into the data, of course, we saw some disparities, and this is clear. 10% in non-Hispanic white, 14% in Hispanic, 18% in Black. But when you break down the numbers in the Black population, you can have some low numbers as of 10% to high numbers up to 20%. So this shows that it's really more driven by socioeconomic and lifestyle than the genetic factors per se. Of course, there are more and more studies undergoing to look into genetic contribution of the gene mutation into Alzheimer's disease in Black population. But now what is out there is that this is probably not due to our genes, but more due to lifestyle. And when you take also people in the same family, of course, we tend to follow the lifestyle of our parents, right? So a family who is very active and exercising every day, from the morning and early in the morning, they'll take out the kids, they'll exercise, to a more sedentary family. So you could see how also in the same family, it's not the gene, but more like the lifestyle that could be driving this. And again, we need more clinical trials and more studies looking into this. What we know and what is sure is that the risk factors, diabetes, hypertension, hyperlipidemia, are more common in African American population, and this increases the risk of vascular dementia. This is known, and this is a fact, and this could also lead to potentially Alzheimer's disease due to the changes. So what are the common reasons why people come make an appointment to the memory center? It ranges from people who are having concern, oh, I feel like I'm having some memory issues, I'm misplacing things at home, or I feel like I'm more forgetful, or my mom or my dad had Alzheimer's disease and really want to be checked, but I feel fine, I'm functioning, I'm doing everything by myself. To people who are brought in by their children, by their spouse, because they are concerned that they're seeing some memory issues for some time, but now this is getting concerning. So either it's self-driven or driven by like people care for that person, and then they're brought in. Regardless, we always want to have collateral information. Even if someone comes by themselves, I'll ask, can I please talk to your spouse? Can I talk to your daughter or to your son or to a good friend to hear from them if they have seen changes as well? Sometimes people could be over anxious about it, right? And then when we get information, they're like, no, she's fine or he's fine. Or being dismissal and say, I have no problem, while other people around them, they're very worried. So we really want to hear from people around them as well. Some people really want to be able to plan. Listen, I live alone, I have no children, I really want to know. So do I need to live in an assisted living? So really like the need to plan. So we really get different reasons, and we value all those reasons for visits. So how is an assessment driven? So a lot is in the history and really listening to, I do a lot of listening, letting people talk and hearing from them their concerns and how it is impacting their function, hearing the story as well and who this person is, right? What was the job before, the profession, the hobbies before, and how is this impacted by the cognitive concern? So a lot of listening from the patient, from collateral information. Sometimes after good history, I do not need a cognitive test, right? This is a clear-cut dementia stage. And of course, we need some of those testing just for insurance purposes or for testing to justify some tests, but sometimes just the history is enough to understand that this is dementia and at what stage we are in. So the cognitive tests that we run really depend on each case. Sometimes it's a very quick one based on the domain that we are testing. Is it memory? Is it language? Is it executive function? To a longer version of the neuropsychological testing, which is a 2-3 hours of testing. So depending on the case, we'll decide what amount, like extent of testing we need. And of course, we'll do a comprehensive physical exam. We'll run some blood work just because we want to make sure that we don't miss anything. Is there anything that is not Alzheimer's that is leading to these memory issues? Very rarely. We have syphilis, very rare that can happen. The B12 issue can lead to some memory difficulty, but not to dementia. But you want to make sure that you correct it, so at least you give all the tools that people have, everything that we can to help with the brain health. The brain scans really depend on each cases. In some cases, we go to an MRI, to a PET scan, to the extreme. In some cases, we don't even need a scan. So it really depends on what we are looking for. So the spectrum. So when we talk about cognitive changes, we have to understand that those changes happen over years. So Alzheimer's disease, this is a long process over several years or decades. Vascular changes also do not happen overnight. Of course, when people can no longer compensate for the changes that are happening in the brain, where I'm losing some amount of neurons, but I'm still able to compensate, we don't see it. When people reach a certain threshold and they can no longer compensate, even taking notes, writing down is no longer enough. This is when we start seeing those changes. So the preclinical stage, we don't see it, but there are changes happening. To the mild cognitive impairment, it's like when there's a decline in cognition, but it is not impacting function. The person is functionally independently because they are compensating, taking notes, putting things down so they can handle their bills, they can travel by themselves. So it is mild cognitive impairment. We talk about dementia when people need other people to help them. Now I need my daughter, my son, my spouse to handle my bills, or someone else to handle my medication, or other functions that need to be handled. So this is when we talk about dementia. Dementia has different stages. In the mild stage, people need support for the high level of function. They need someone to come in maybe a few hours a day, fix the meds, making sure the mails are handled, the finances are handled. If they want to travel far, they can manage in the neighborhood, they can manage at home. To the moderate stage where people need like constant supervision, there's a risk of safety, wandering. This is when you really need like full-time support. And the severe stage, of course, is a stage of complete dependence. Alzheimer's disease, very, very quickly. The typical history is that this is progressive, memory decline very slowly. This is what we call amnestic, because based on memory, sometimes we can have the language variant. People can no longer find the right word or say the word. They would describe it. This is called the language variant. It's happened also in some atypical cases for Alzheimer's. More in younger people. You have also the visual spatial variant, where people have distortion in the visual field. And again, this is like something that happens slowly. This is what we call is progressive. And then to a point where it's affecting daily function. The neuropsychiatric symptoms usually happen with disease progression. But again, some people can start having delusions at the beginning. Let's say thinking that people are stealing the belongings in the house. This can happen at the beginning too, but the more challenging behaviors will happen toward the end. And this is where there's a higher burden and leads to long-term care placement. The depression is very common in all type of dementia, because it's frustrating not to be able to remember. So we should always figure out if there's some neuropsychiatric symptom. Is that depression, or is that really like behavioral symptoms of dementia? So the diagnosis is a lot of history, again, as I said, and testing, MRI. The MRI is basically meant to rule out significant vascular changes, rule out other etiologies like brain lesions, strokes in the brain that will make you think about more vascular issues. MRI could appear normal in people with Alzheimer's disease or show some volume loss. We have to remember that it's not because someone has volume loss that they have Alzheimer's disease, right? We don't go from a scan to make a diagnosis. We go from the clinical diagnosis, then we get the brain scan. In some cases, as I said, we can get a PET scan that will show decreased metabolism, decreased function in the memory areas. We do not scan the brain of people to find decreased function and say, hey, those people have Alzheimer's. We don't go the other way around. Some people will get some amyloid markers, amyloid tau markers. So I have to stress here that there are some tests that are out there, some blood work that are out there to look for Alzheimer's markers. Those are not validated to make a diagnosis of Alzheimer's disease. We have to be very careful with that. We do, at this point, we do the brain fluid, the cerebral fluid analysis in people who have already a diagnosis of a cognitive impairment. We are trying to figure out why this is happening, because other tests are not enough to diagnose it, or if we are planning to give those new infusions that are available for early cases of Alzheimer's. So we have to be careful how we use those tests. Prevention. So there are things that we can modify. There are other things there is nothing we can do about it. There's nothing we can do about getting older. And this is the main risk factor. Genetic, as I said, is usually in early onset, less than 65-year-old, and it's very few percent, 1%. A family history increases the risk of Alzheimer's disease independent from genetic mutation, but just like someone, we have diabetes in the family, there's an increased risk, but it doesn't mean that this will happen, and we see a lot of anxiety around this, but we'll talk more about those factors later. There are things that we can modify, and it has been shown that if we all do this, we might be able to prevent up to almost 40% of dementias worldwide. So being more physically active, treating underlying medical issues, hypertension, obesity, diabetes, and stopping smoking, handling hearing impairment, aiming to more education, especially when we are younger, address social isolation. This has been shown to be a risk factor as well. Depression, excessive alcohol consumption, Traumatic brain injuries increases the risk, and more studies are looking into air pollutions. They still did not determine how and which one, but there's an increased risk. It's never too early, too late to start preventing having a good lifestyle. So this is a recent study that was published by the European Task Force, looking at how we could actually prevent dementia in memory clinics. And if you look, of course, we have the gene mutation, the ApoE, who is one of the main genes also leading to Alzheimer's disease. Having one gene, there's a relative risk of 1.9. Having both genes from both parents, of course, increases the risk. But when you go down and you see hearing loss, 1.9 increased relative risk is the same as having one gene, right? Abnormal gene. And looking at hypertension, alcohol, obesity, depression, social isolation, physical inactivity, you could see how much those impact memory. We are all worried about the genetic contribution, but you could see also how much a healthy lifestyle can actually impact cognition. So holistic care. So when we talk about the care of patient living with dementia, it's not just like, okay, give me a pill to fix the memory. It's really much far beyond this. It's really making sure that the person is cared, of course, medically, making sure that everything is being treated appropriately, making sure that the social context is also where is the patient living with? Who is he living with, or she's living with? How is she spending her day? What's her hobbies? It's really taking care of the person as a whole. Additionally, we take care of the caregivers as well. So taking care of a patient living with dementia is really taking care of the diet, is really taking care of the whole, whoever is caring for them. So management, I'm trying to go quick so that we will have time for questions. So physical cognitive exercises. So often people will ask, what physical exercise is good? So we say if someone can walk every day for half an hour every day is a good thing. Recent studies shown that the more we exercise, actually the best protection we have. So the more you can do, the best it is. But of course, a minimum of 30 minutes every day will be great. Cognitive exercise, often I get the question, what kind of cognitive activities we can do? I would say it's really targeting or tailored to the person's interest, right? Someone who never did puzzles or crosswords, you cannot force them to do it. Maybe it's more like something in the arts, craft. So you have to know who is the person in front of you, who was what she or he used to like when they were younger, a young adult, and then you will be tailoring the cognitive exercise to them. Is it like more computer? Is it like more hands? So it's really something that you have to do individualized approach here. Social engagement is huge, avoiding social isolation. So we cannot say that enough. And we are thankful to have an Alzheimer's Association and all those resources for our patients. Address risk factors, treat cardiovascular risk factors. Sometimes people, when there's a diagnosis of Alzheimer's, they tend to just follow with whoever is treating the cognitive impairment. I would say make sure that there's always an appointment with the primary care physician, that things are not overlooked. As a geriatrician, of course, I'll always make sure to oversee all the diseases and make sure that the medications are safe, things are under control. But sometimes it's not always the case depending on who is treating the memory impairment. Discontinuing inappropriate medications, all those Tylenol PM, Advil PM, all those PM med have to be stopped. Anything that is meant to sleep have to be reviewed and make sure it's safe. And all the substances that are being used have to be discussed. So it's really like seeing everything that the person takes and make sure it's like safe to be used. Address safety. When we say safety, it's not just wondering, like safety around medication management, that a person doesn't take several times the meds because they forgot that they took it, or forget to take a medication that will preventing, let's say, a stroke. So addressing safety is around home, medication, but also the financial safety. Share community resources, screen for caregiver burden, discuss disease progression. So sometimes people are being treated or with the family and they don't know even what we are treating. I think like talking with them and discussing, okay, this is this is the diagnosis, this is why it's happening, and this is what changes happening in the brain, and how could this progress? And let's plan for more support if it's needed in the future. Of course, we want to make sure that the disease doesn't define the person. So this is a brain disease and this does not define the person. We have to make sure that we preserve people identity and authenticity and really respect them as who they are. Pharmacological management. Okay, so when we try to care for patient and the care partners and the physician, I think we all have to meet somewhere. There is the physician expectation, care partner expectations, and the patient, and making sure that we all come to the table and say those are reasonable recommendations for everyone. So those are pictures, and I got the approval to share of one of my patients who was doing pretty well and then had an acute illness, was in the hospital. And when we say that, we have to make sure that we treat the underlying acute issue. The thought was, okay, she was very, very sick suddenly, and she was in the hospital, she wouldn't make it, she was going to hospice. But when you take the history, this lady was barely at a mild dementia stage, right? Why are we putting her now on this advanced stage? Just because there was this acute illness. So by treating her disease, getting her back to doing her physical therapy or activities. Now she's drawing, she's very happy, she's having a wonderful quality of life. So it's important to really see this whole picture. And those are resources that we share. As you can see, Alzheimer's Association is up there. And my family support program is also a program that we have providing support to patients. And so in conclusion, so it's important to prevent healthy diet, exercise, cognitive social engagement, treat optimally all the medical comorbidities from younger adulthood. The diagnosis of dementia is really a comprehensive evaluation. And we know Alzheimer's disease is just a type of dementia. Even though it's the most common one in 70–80%, it is a type of dementia. We need a lot of collaboration when we care for patients living with dementia. We need more representation, and we need more support for our communities and for all the communities. And there's a new master plan for aging. We are expecting a lot to happen. So we're in there, we stay positive. Thank you so much, everyone. Stop sharing here.
Thank you so much, Dr. Tall, for that very informative presentation. I hope that we all will leave here with something that we can apply to ourselves and also to share with others so that they too are aware of what it is to pursue a diagnosis and also what to do to prevent your risk and reduce your risk in being diagnosed with dementia. So at this time, we will open up for Q&A. As a reminder, you can utilize the chat or you can raise your hand and I will unmute you to ask your question. Okay. So Norm.
Can you hear me?
Yes.
Oh,
Yeah.
hi. Thank you so much. It was very informative. I just one short question. Cholesterol is high cholesterol and dementia. Is that a marker? Or is that because my sister, I have a twin sister who has some marked memory loss. Her cholesterol just shot up to 270, and I'm wondering if she hasn't been diagnosed yet as having, what form of dementia, but would that, I got nervous when you said that because I'm thinking that would be like a correlation between this high cholesterol. Is that the case?
So,
Does it increase? I'm sorry, and then I'll just stop. Does it increase immediately when you have Alzheimer's, specifically the cholesterol?
So it's a good question. So when we talk about cholesterol, is that we put together all the cardiovascular risk factors, right? Hypertension, cholesterol, diabetes, obesity, because those leads to vascular changes, right? Narrowing a blood vessel, decreased blood flow to the brain. And those could lead to also stroke. So what you want to find out, what you want to make sure is that, of course, your sister's cholesterol is being treated, having her assessed and checking if she has maybe vascular changes in the brain or maybe strokes that were not detected. For you, I'll make sure that you have a physical exam with your primary care physician, check on your cholesterol level. The decision to treat cholesterol is based on some data and some guidelines. And if you meet criteria for a cholesterol medication, please take it. In the past, there were those thought that cholesterol pills would lead to memory issues, but actually studies are not did not prove that, right? So a lot of people who needed to take the statins refused to take it because they were afraid of those results. And then this led to having strokes, vascular changes, and also heart attack, right? So when we talk about vascular changes, this is not only the brain. That could lead to also having heart disease.
Thank you.
You're welcome.
Thank you, Dr. Tall. Stephanie, if you can unmute and ask your question.
Yes, good afternoon. I have a question. I've been recently taking my father to the neurologist, et cetera. He's been doing everything under the sun. However, I noticed that the exams given in the neurology office don't seem really culturally affirming, or they seem old, and the assessment is given very fast. So I was wondering, at the memory center, do you have, or the assessments or tools that you use, are they culturally affirming? We're of Haitian culture. So I find that some of the words that are being asked or the images doesn't really correlate to the culture. So I'm just wondering, are there different assessments that are more culturally affirming in your office, or things like in developments just across the board, to be able to, properly see where someone is? Because he did well in one, then he didn't do in the other, but the way which the test is just given, it just didn't seem like it was supportive of just even his level of learning and how he learns versus how the test is given.
Yeah. Thank you. So yeah, there are tests that, we have to make sure that the tests that we use are culture sensitive. There are some tests that are validated for native English speaking patients, right? And in some cultures. So I use, when I assess a patient, I'll make sure that first, who is a patient in front of me, what's the background, and then I will tailor the test that I will use for those patients. There are some tests that are meant for culturally diverse patients, and we have those tests. And the neuropsychological testing also, we make sure that we follow those cultures, and the education level is taken into consideration. And as you said, some tests, let's say I had a patient and some of those tests would say velvet. It was like, what velvet? What's velvet, right? So, and of course I was with a trainee, and I was saying, you see, so those are not the tests that you want to use here. So I agree with you. It has to be tailored to the patient that we're assessing. And again, sometimes we don't need extensive tests, honestly, to diagnose. So it's a case by case. I would say make an appointment with our center. We'll be happy to see your dad.
Oh, I have an appointment. Thank you.
Okay, great. I'll see you.
Thank you, Dr. Tall. And Dr. Tall, would you recommend that a patient brings that up with their doctor, and that they would like to know about the different culturally affirming tests that exist?
So I would say we will hope that the physician that are making the assessment will be able to determine what is the appropriate test, right? Sometimes being in the room I mean, when I administer for the full neuropsych testing, usually the family members are not in the room, but for a quick assessment, they can be in the room. I mean, I think it's fair to either, even if you are not in the room, asking after, right, what did you get on the testing, and just seeing what was done, right? And then you'll be like, I don't think my dad would even know that, even at baselines. That could be helpful.
Thank you. Okay, so I'm going to jump to the chat just a bit so that those folks don't feel neglected. We have a question from Elaine. Elaine would like to know what can be done to reduce harmful plaque in the brain and what medications currently on the market can help.
What can be done to avoid those plaques is everything that we spoke about prevention. Some people do the right thing and it still happens. So it's still unclear what is triggering, right, the whole process happening in the brain. But what we know is that those interventions decrease the risk of those changes happening in the brain. But of course, it doesn't avoid it. There's some diet also that's I haven't spoken about. The Mediterranean diet has been proven to also help slow down the cognitive decline. There's also the MIND diet, which is a combination of the Mediterranean diet and the DASH diet. The DASH diet is a diet for hypertension. So combining those two diets is called the MIND diet in people with hypertension. And cognitive impairment has been shown also to be effective in terms of like helping preventing. Now, what treatments are available? There are some medications just for symptoms that have been available for decades. Those are not addressing the disease process, right? Now there are new drugs, and you all probably most know about lecanemab. Lecanemab is the new infusion that has been fully approved by FDA early July, and it's being administered slowly. It's happening, but it's happening. So this is what is actually meant to target the disease process. The accumulation of the amyloid in the brain, it kind of like acts at a step during that accumulation path and kind of like work on the disease process. So Lecanemab is the disease-modifying drug that has been newly approved. There's a lot of criteria that have to be met, right? We have a whole algorithm for someone to qualify for it because we know about potential side effects. Of course, we hope that this would have benefits. The data are limited at this point to 18 months of study of this drug. But again, this is a real hope for me and for all patients living with dementia and the caregivers, and also for people in the field. This is a hope that there are improvement happening in the field. So Lecanemab will be what would be the disease-modifying drug. It's meant for very, very early cases. Mild cognitive impairment to mild dementia stage up to a certain point. So some of the cognitive tests used are meant to kind of draw the line who qualifies or not. And we need to prove that there are amyloid in the brain. So people need to have either this lumbar puncture, proving the Alzheimer's markers in the brain, or having a PET amyloid scan proving it. So it's like a whole process. But yes.
Thank you, Dr. Tall. And on treatments, we do have a link that was dropped in the chat, so you can go ahead and access that if you want to read more. Another question that has come up in the chat, Dr. Tall, is when you're visiting a neurologist, what tests are usually done to test on cognitive functioning? And also, do those tests help to determine what phase that person might be in the disease? And then second part, would you recommend, or what would you say in terms of should a person see a neurologist or should they go to a memory clinic?
Okay, so first assessment, right? So again, the test that is being used has to be determined by the physician assessing the patient, because they need, according to the story that you hear, then you decide on the appropriate test to use. That is the first question. Could be a short one, could be a long one. Then you have the scans that come with it. Now, in terms of like who to see, so you have different people. I mean, we have to remember that the population is aging, so not all people with cognitive concerns could be handled by the group of neurologists that do cognitive neurology or the geriatrician who do memory assessment or the memory clinic. So that's why the appointment wait time could be pretty long. And a primary care physician should be, and we are working on improving that, should be able to do the initial assessment. Some cases are clear cut. You don't need a specialist to tell, but some people are just not comfortable telling patients that they have Alzheimer's disease, even though it's clear cut. So primary care physician should be able to do the initial assessment, do the initial testing, get the MRI, get the blood work, and refer if they have to, right? Especially early cases where we might be able to have a specific intervention. So memory clinics, so depending on where you are, in our center, you have geriatrician, you have neurologists. So depending on the age of the patient, the complexity of the disease, then people will go either to neuro, geri, but we all would do the same work, the same assessment. So memory centers are across the city. We have a couple of them. So this is how I would determine, but I would say always start with your primary care physician and talk about it. Sometimes we don't even talk about it. It's like talk about it with your primary care physician, know who is your dad's primary care physician, and say, hey, I have concerns, and that is helpful.
Thank you, Dr. Tall. So I know we have a lot of questions coming in, which is great. That means that, yes, we know this is an important topic and we want to learn more. I am going to ask that we're mindful of the time when you are sharing your questions so that we can get to everyone as best as we can. So I'm going to jump back to those who've raised their hands. Michelle.
Yes,
Okay.
I'm here.
Oh.
Thank you so much. I ran to the phone. Okay, so I know that, first of all, thank you so much for having this. This is wonderful. And all that you all do at Alzheimer's Association is amazing. I have a lot of questions, so if there's ever a lull, which I doubt that there is, feel free to come back to me. So 2 things. One, I would like to say, how do we find out about the newest medications and the way that they're being used? Because I find sometimes in talking to other people and other people of different cultures, it seems that they might be apprised of different things, and it may be because of some of the bias we talk about, but it also may be just the quality of the physician and the physician being able to stay attuned to what's happening. So for example, with the Aricept, I understand you're supposed to only be on there for a certain amount of time, but it seems that you basically put a person on there and they just stay on there and they just increase the dose. So I want to know, is there a time that you have to take them off, and the new treatments, and also adding memantine, I might be pronouncing it wrong, Namenda, to Aricept seems to have some good results, I heard. So that's the first question. And the second question is, going to the hospital, I found, has been a treacherous place for me and my mom. So one thing that I've learned is to, at the beginning of the, getting triaged or whatever, filling out the form, the ADA form, American Disabilities Act form, and considering myself to have to be required to be with her as either her interpreter or support for this condition, so that they can stop hassling me and trying to push me away and having her answer questions when they know very well she cannot, if they have any idea about Alzheimer's. Thank you.
Okay, so let's start with the first part. So treatment. So donepezil, so I break this down into symptomatic medication for symptoms, right? It's not a disease-modifying treatment to the newest disease-modifying treatment. Donepezil is started, so it's meant for dementia stage, not for people. So mild cognitive impairment, sometimes it is started. So I believe when it is starting mild cognitive impairment, that means the physician has concerns that actually, even if they're not calling it dementia, they're worried that this is progressing to dementia and they're starting it. So it's meant for mild dementia. It's reasonable to start it if there's no contraindication to it. There are a couple of contraindications that I would be careful giving it to patients. And so it's meant to kind of help people function at the plateau, right, for longer time. So it's not meant to improve memory, it's not meant to fix it. Memantine is added after to donepezil. So it has been shown that donepezil and memantine together are more effective than just one. When you say that it started and it never stopped, honestly, when you start someone on donepezil and then you add memantine, we would keep that person on unless there is a side effect or you feel like really the person is advancing to severe dementia stage, then there's a conversation in terms of like starting to decrease the meds. Why? Because when even though we feel that this is not helping at all, when we decrease it, especially when we stop it suddenly, you can see a faster decline, just because it was kind of like a supportive symptomatic medication. Of course, as the dementia progresses to severe stage, when people have decreased appetite, we have to start decreasing those meds because especially donepezil could lead to decreased appetite, weight loss. So this is something for me, which is a red flag. Patient is starting to lose the appetite, I need to start decreasing and removing those meds. So if the person has no side effects, eating well, having a good quality of life on those meds, even though we feel like memory is declining, I would not stop it. Of course, I would not start it if I have concern that this is not going to be helpful, but when I started, that's mean I'm convinced that it might be helpful. I'll keep them on unless there's a concern. What's the other part of the question?
Yes, thank you. And then the ADA form. Thank you so much. To help support us in the hospital. Thank you.
You have to be in a hospital whenever your loved one with dementia is there, right? There's no question. So, and I believe at NYU we're doing a good job. We're doing the best we can to allow people stay with their loved one because like having a kid in the hospital who like they want safety, they want their loved one around them. So please continue to advocate for your mom.
Thank you so much.
Dr. Tall. Yes, so we have time for maybe a couple more.
It's okay.
Okay, thank you, Dr. Tall. Mel?
Hi, good morning. Thank you, everyone. Thank you, doctor, and thank you to the team for organizing this. I just have a question around the causes for dementia and Alzheimer's. I know on an earlier slide you shared information on genetics and then mentioning kind of social factors. I'm curious, could you say a little bit more on like what some of those social factors could potentially be?
So when we say social context is when you take the lifestyle, when we talk about exercise, how exercise is important, how eating healthy and having physical activity, cognitive activity, sometimes it could be related to the social context, right? Being able to exercise, being able to afford a healthy lifestyle, the Mediterranean diet, sometimes it could be also social and economics. Cultural, right? Some cultures tend to eat more red meat and fried food, right? This is culture, not to criticize the culture, but we know that let's say the Mayan diet, we have to reduce red meat, we have to reduce cheese and favor fruits, vegetables, beans, and nuts, right? So this is also where culture could play a role here. So culture is your healthy lifestyle, your exercise. Social interactions, some cultures are very social, right? Like the patient with cognitive impairment is always surrounded and they have the kids, the grandkids around them, they're happy. Some other people, they're more socially isolated. So this is where the socioeconomic and social context could actually interfere with the disease management. And of course, we hope to aim on all fronts to address those issues. The genetic contribution, as I said, unless this is early onset, usually this is not a genetic disease, Alzheimer's disease. And when we talk about mixed dementias, and very quickly, let's say the new drug, it's not because someone has Alzheimer's disease. Let's say people in the 80s or late 80s, usually they don't have a pure Alzheimer's disease. They might have it, but they may have also a vascular disease, right? So you can treat as much as you want the Alzheimer's disease, giving them the infusion. You might treat the underlying Alzheimer's disease, but you're not treating the vascular contribution here. So the mixed dementias also will come into consideration when it comes to treatment.
Thank you, Dr. Tall. So I know we are at the hour. Do you, and no
I would
pressure,
I
do
would
we,
say.
yes,
I would
okay,
say
thank
go for
you. Thank you very much. Okay, Carrie?
Hi, good morning. Thank you, Dr. Tall, and thank you, everybody, putting together this Zoom. Um, I actually am hoping to get my mother to see you. We have an upcoming appointment. I have failed miserably to get her there in a previous appointment, so I took this opportunity. Mom does have vascular disease, is feisty and convinced that there is absolutely nothing wrong. And with respects to treating symptoms, I am, I guess I feel like I'm between a rock and a hard place with I am in contact with her general practitioner that gratefully I've known for the last 5 or 6 years because mom is 85. But yet, he'll go along, she needs cholesterol medication. She's got a blockage, a bad one. And after 3 cholesterol medications, I mean, even a non-statin, I mean, it really just, I mean, behaviors that I'm like, this is not mom. And delusions, I mean, it just changing the locks on the house, pretty severe. And if that's not your realm, I do apologize, but I just feel like there has to be medication. She is on the Aricept, the Donzepil, and they keep trying different, but she's alone. And she, like, these symptoms, she's finally, yeah, I'll let you finish.
So-
Go ahead.
No. So do me a favor, Lana, can you get her number contact? I'll have my clinic call you. We'll get you in. We'll overbook. Yeah. So I don't do
you.
a consult on a Zoom call.
Thank you, Dr. Tall.
Yeah,
Okay, so
thank
we'll
My
take
apologies.
Amy? Is Amy?
Amy, yes.
Amy, I will see your mom very,
Oh,
very
sorry, no,
soon.
that was Carrie, but we have Amy,
Carrie?
who's
Okay,
also.
Carrie. So Carrie, please give your contact. We'll get you in.
Yeah, thank you. I apologize.
No. And I really hear you. And it feels to me that you really need the support. And I apologize that this is taking so long. But we'll take care of you and your mom.
Thank you.
Of course.
Thank you. Ami?
Yes, hi, Dr. Tall. Thank you so much for just that very brief last moment of compassion. With that question that just came before, I'm just so grateful that I heard that. And thank everybody that's involved in this. And Linda, you did great. I have 2 questions. One is an easy question. Because and then one is a harder. I'll go with the easy one first, because I was surprised to hear one of the red flags was hearing loss, and I'm going to try to guess at that brings on isolation, but I could be wrong. So that's the first question. The second question: is there a correlation between age and the use of medication? Because is there a time when brain cells stop regenerating? My mother's in her 90s, and I try to think back at all the people who I have known, and it crosses different demographics. And for me personally, I've never been fortunate enough to see someone who was successful once they got on medication. And so I'm wondering, my mother, basically, she was on medications in her 80s. So, and then I ran into someone who got on medications when they were much younger. So is there some point in time when, if the medication or the dosage is not working properly, then there's no turning back, versus is there a point in time when you can make adjustments and then the cells will regenerate? So those two questions. Thank you.
Thank you. So I would say the hearing loss. So of course, hearing loss leads to social isolation, but it also has been shown that hearing loss, people who need to use more the brain reserve to actually process it. So and of course, this leads to more brain burden. So the hearing loss has been definitely implicated with being a risk factor. Of course, it doesn't mean that because someone has hearing loss, they will have dementia, but it is a risk factor. And you could also understand how someone with decreased hearing, you're telling information they wouldn't be able even to register it. So making sure that we address hearing loss is huge. Coming to the medication, there's no age threshold to start the pill. I am very cautious starting the meds in people in the 90s just because there's an increased risk for side effects. There's an increased risk, there's less efficacy, right? And so using it, unless the person is really a very healthy 90-year-old, really functioning person, those medication could have some interactions with some other meds. I'm very cautious when I use meds. Again, it's not, when we talk about meds, even geriatrics, it's not about age, right? I don't put age as like a target. It's really like, how is a person functioning? What are the medical comorbidities? And then I make a clinical decision, not based on the age number.
And the brain cells, is there a age factor?
No, so those meds are not meant to regenerate the brain cells. No, all those meds are really meant for symptoms. So it kind of helps the neurotransmitters stay longer in the brain, and that doesn't regenerate the cell.
Okay. Thank you. Thank you.
Thank you so much, Dr. Tall. Thank you for every person that has joined this webinar. I hope that you learned something today and that you will share it with someone else so that they too will be informed. Thank you to Linda again for providing that awareness presentation to us. And another big special shout out, thank you to you, Dr. Tall, because we do appreciate you giving us that additional time to answer some more of the questions that came through. So we do invite you to, one, stay connected with the Alzheimer's Association New York City chapter. You can visit us at alz.org/NYC. We will also upload this session to our YouTube channel, so you can feel free to watch it again and share it with a friend or someone else who could benefit from this information. Again, we truly appreciate you all taking the time to be here, and we hope that you will have a great rest of your day.
Thank you so much for having me, and great job, Dana and Linda, for this conference and for everything you do. Thank you all. I wish I could see you all and talk to you all. Take care.
Thank you. Thank you,
Thank
Dr.
you. Thank you, everyone.
Thank you.
Thank you so much.
Thank you, Dr. Tall.
Thank you, bye.
You're the best.
Thank you.
She is the best.